Hello, everybody, and welcome to the Functional Formularies, Blenderized Tube Feeding in Children with Developmental Disabilities. I am super excited to be moderating this event. I'm Laura Doherty. I'm the National Clinical Manager for Functional Formularies. We have two guest speakers that I'm going to introduce here in a second. But just as a reminder, all of our attendees will remain on mute until the end, where you will be able to ask Q&A through the question or chat feature. You can certainly ask a question as the webinar is going on, but we will have a specific time to answer those at the end. This webinar has been approved by CDR for 1 CPE unit. So your certificates will be emailed out after the event by the end of the day. That will come in a separate email from us. So just keep that in mind. It won't just automatically pop up at the end of this webinar. It will come in a separate email reminder. So without further ado, I want to introduce our amazing speakers today. We have Dr. Teresa Johnson with us. She is a registered dietitian nutritionist with over 35 years of clinical practice and teaching experience. She has a doctorate in clinical nutrition from Rutgers University. Her primary clinical practice has been in children with severe developmental disabilities and inpatient rehab. Her current research projects are on the efficacy and safety of blenderized tube feedings. Dr. Johnson is a professor in the Department of Kinesiology and Health Promotion at Troy University. And then our second guest speaker today is Shawna Walker, and she is a registered dietitian nutritionist with over 30 years of clinical experience. She obtained her Bachelor of Science in Scientific Nutrition from Texas A&M University. Served as Southern Colorado Dietetic Association President, VP, and Secretary, and was recognized as the Young Dietitian of the Year. Her clinical experience includes working as a pediatric dietitian in the hospital, specialty clinics, and outpatient settings. Her current passion is promoting the benefits of enteral whole food blends with her developmentally disabled clients. Shawna has participated in blenderized tube feeding research and is currently working as a dietitian and feeding team lead at the Resource Exchange in Colorado Springs, Colorado. So with those amazing introductions, I'm going to let Dr. Johnson take it from here.
Great. Thank you, Laura, and thank you for the opportunity to share a little bit of our research with the audience today. I need to disclose that I do speak for several pharmaceutical companies that you see here, and Shawna also speaks for Functional Formularies. So today we're just going to go very quickly through the published literature on BTF in this special patient population, and then look more specifically, as Shawna will, the practical aspects of transitioning from commercial to BTF, look at strategies to assure that it's adequate, and troubleshoot potential issues in this patient population. And I'm going to cut my camera off so I don't distract myself. All right, there we go, just in case. Are we off? Hello?
I can, your camera's still on, but I can.
Oh, there we go. That should be right. Thank you.
Now you're good.
All right, so what constitutes a blenderized tube feeding? Well, it's about as diverse as anything that can go into it. We have historical accounts of physicians using clay pipes and eel skin covered whale bones attempting to feed patients who were unable to eat by mouth. And as you might expect, the results were disastrous. It was not until the 20th century, with the development of polyurethane tubing, commercial blenders, and improved surgical techniques, that enteral nutrition became safe and effective. And blenderized tube feeding made in hospital kitchens were poured through large bore nasogastric tubes into the stomach, and I have a vague remembrance of this. By the 1960s and early 70s, these food mixtures were gradually displaced with chemically defined sterile commercial formulas. And this is what we were trained on. You know, the other, I do remember seeing as a small child, somebody getting a blend, put it in an NG tube, a home health nurse for our neighbor, and that really made an impression on me. But we were all trained in the 80s and forward, don't put anything in that tube except water, formula, or medications. And maybe some of you never even heard of a BTF because it just sort of went the way of the dodo. Consequently, giving patients pureed food through a tube became a thing of the past, except for rare situations where formula wasn't available and we had to whip out the secret recipe. All right, let's advance. Come on, advance the slide. All right, there we go. So by the turn of the century, healthcare providers reported patient interest in use of BTF despite a non-supportive healthcare environment was occurring. This demand for a more physiologic tube feeding was due to the increase in the home enteral nutrition population, coupled with the message that we dietitians have been giving for years. Plant-based diverse diets confer health advantages. Patients and caregivers began to experiment with their tube feeding ingredients, and they experienced many improvements. These anecdotal reports spread among the tube feeding community, and the return to BTF in our century began. This movement has created quite a stir in the enteral patient population. Healthcare providers and companies that provide enteral products have all been affected. So a definition here is food and liquid pureed enough to be given in an enteral access device. Sounds easy enough, but there are many versions of BTF, including full or partial, recipes made from whole foods, some made from baby food purees. There are commercial blended food products and plant and food-based commercial products. While a homemade BTF must be administered within 2 hours of preparation, some commercial food-based formulas may hang for hours and be delivered successfully by pump. Some clients utilize both standard commercial formulas and BTF. For example, a continuous feeding at night with bolus purees during the day. We have vegan and organic options. Numerous BTF recipes and resources are available on the web, and over a dozen commercial food or food-based products are offered by pharmaceutical companies. Why all the fuss? As stated earlier, this interest and demand has been patient-driven, and most published work has been conducted in pediatric patient populations with over 20 papers in print, and the majority indicating positive outcomes when proper oversight and follow-up is provided, which I say is true of any tube feeding. We did a 2015 survey of 242 pediatric RDs in clinical practice, and 57% said they used or recommended BTF to their patient families. 77% reported positive outcomes. 83% rated parents' experiences as positive. And the primary reason that they turned to BTF were parent request or tube feeding intolerance. Those dietitians not using BTF cited concerns about formula safety, those things that we were taught in school, worry about bacterial contamination, an inconsistent nutrient composition, even clogged tubes, although these are rarely observed in their actual clinical practice when they have patients using them. More recent surveys have collectively found that more dietitians are aware and supportive of BTF. However, knowledge and implementation in clinical practice have remained rather stagnant. When we look at literature in adult patients, we find there are less papers. I found about 8, and again, they were positive outcomes. But the studies have been small and heterogeneous. As you can imagine, with a type feeding substrate of BTF, you're not going to be consistent across the board with that. And they've also looked at different variables of interest. But in reality, patients and caregivers who have experienced the benefit of a blend, they don't care about what the research papers say, or even conventional practices and policies and procedures of healthcare facilities. I have found that this patient population is quite passionate about their decision to use it, and when they're not supported by the medical community, they will often go it alone. They'll seek information that may or not be appropriate. As healthcare providers, we need to listen to what our patients and clients are telling us. After all, we are the patient-centered care generation. Now, my journey began nearly a decade ago when we weaned a little boy from standard formula to BTF at his mother's request. This little fella was born with bronchopulmonary dysplasia, and as he grew, was unable to maintain his growth trajectory on oral feeding alone. The doctor placed a G-tube and began night feedings. The child did not respond well at all. In spite of multiple formula changes, medications, 2 fundoplications, and every protocol found to reduce GI symptoms, he could not tolerate even trophic feeding, and he stopped refusing oral food altogether. However, after the clinic dietitian weaned him to BTF, all of his feeding issues resolved. He was able to eventually be weaned completely from the tube feeding and is a happy, healthy, normal teenage boy today. And we published that case study back in 2013, but it was only the beginning for me. We wanted to know if other parents experienced the same outcomes, so we did a survey of parents with children on feeding tubes who were part of an online support group from around the country. I need to back up a little bit. And these results are summarized on this slide. We had 430 parents participate. 50% were using a blend and 50% were on standard commercial formula. The reason they chose BTF was they wanted a natural feeding. They had heard that it would be a bridge to oral foods to reduce tube feeding intolerance. Some had allergies. Some reported it was less expensive than formula. Only 2 out of 217 parents reported any negative experience. Reasons for using commercial standard formula, as reported by the other parent group, said that they didn't know about BTF or they didn't feel supported by the medical community to use it. Others said there were time constraints, and they also said that they had to have a particular special commercial formula because their child had a unique metabolic disorder. And finally, the child was on J-tube. But more parents of the BTF-fed children reported that growth goals were met and they had less GI issues. There was a concern, however. Less than half of the BTF group had feeding oversight from a healthcare provider, and I think this is reflective of the hesitancy on the part of healthcare providers to even consider it. But we can't ignore patient or caregiver experiences. Anecdotal reports that these parents gave us are confirmed in these research papers previously mentioned. You may be aware of that classic 2011 Peniuk paper that first reported benefits of BTF in children who were followed by a pediatric gastroenterologist, excuse me. Let's consider some recent papers. Ron and colleagues at Boston Children's Hospital followed enterally fed children for 1 year. They compared BTF to CF-fed kids who came through. Although the demographics were equivalent between the two groups, the BTF group had less hospital admissions and ER visits, less infections, nausea, vomiting, diarrhea, pain, and significantly higher quality of life and satisfaction scores compared to those children who were fed standard commercial formula. Batsis and colleagues published a retrospective chart review of 23 children followed for 17 months who were switched from a commercial formula to a BTF. 95% with upper GI tract issues reported substantial improvement after 3 months. We decided to take a deeper dive on this and compare outcomes in very young children with severe developmental disabilities. We conducted a retrospective chart review of 34 children where Shawna works. These kids were transitioned from standard commercial formula to either food-based or blenderized whole food. We wanted to know if the type of BTF, whether it was a full BTF or partial, or if a commercially based or a whole food-based formula might impact variables of interest. Charts were pulled between December 2020 and January 2022, which, as you will remember, captured the time of the COVID pandemic. Although this wasn't part of a plan, after all this was retrospective, it worked out very well because during the shutdown, children were at home and there was very little illness typical of the early childhood years. You guys know if you work in a special needs population with the age of these children that was birth to 36 months, a transient illness can have a major impact on study variables. So we feel that this was really a good thing. Of the 34 charts that were complete enough to review, 16 were male, 18 female. The age of transition averaged about 14.7 months, and the average number of months that we were able to follow the kids was 15.3. Again, these children had severe developmental delays with multiple diagnoses, including GI, neuro, genetic, pulmonary, congenital, cardiac, among others. 56% of the children who were transitioned, it was due to parent request, and the others were recommended by the physician. And the BTF, the parents had choices of commercially available products, blended whole foods, full or partial. Shawna works very closely with her patient population to make sure that they get what's best for them. 53% were bolus fed, 44% intermittent, and the remaining were on continuous by pump. A little over half used 100% BTF, and the rest were on partial BTF. We found some pretty compelling results. 74% of the sample experienced an increase in oral intake after the transition. There was a significant decrease in the mean number of baseline and last patient encounter GI medications. That was really amazing. Although every child was receiving a GI med at baseline, with over a third getting 2 meds, by the end of this observation period, almost half were not getting any GI meds at the last encounter with a dietitian. This reduction in GI med use was consistent with a reduction in reported GI symptoms. After the transition, there were no reports of increased adverse GI problems. Emesis, constipation, and reflux were decreased by nearly 58%, 76%, and 60% respectively. In particular, reported symptoms of gagging and retching were reduced in 100% of the kids. Z-scores for weight, length, and weight for length all improved after the transition. Now, to explore any potential impact of full or partial blended tube feeding on anthropometric measures, we collapsed it into 2 groups. 19 got full BTF, and 15 were getting partial blenderized tube feeding. We did some t-tests to see if there were differences in the baseline measure and the last measure Z-score. And if you see these 2 darker box plots, you'll see that the participants in the full BTF group had non-significantly lower weight Z-scores than the group on partial at baseline. You'll also see that the average weight Z-score, they improved in both, but better improvement at the last measure, although these differences did not reach statistical significance. So they were improved regardless if they were on full or partial BTF. To explore any potential difference in outcomes between a commercial blend versus a whole food blend, we again collapsed the sample into 2 groups and looked at weight Z-scores at baseline and the last patient encounter. You can see the whole food BTF group had weight Z-scores that trended non-significantly higher than the commercial group, but again, it was non-significant. And the takeaway here is that whether you have a child on full or partial BTF, and whether it's whole food or a commercial blend, the products promoted improvement in growth and all of the other outcomes that we looked at. Now, of course, every study has its limitations. This was a small sample size. Some of the data we collected was subjective, caregiver reported data. Also, we can't ignore the impact of COVID because it reduced the number of complete charts that we were able to retain for the study. We had 47 potential, but being purists, we didn't want to retain charts that we felt were too incomplete. But as mentioned earlier, the pandemic had a positive impact in that the less illness and the higher ability of the caregivers to maintain the feeding regimen were observed. So that's a good thing. Another limitation is that the patients were only followed up to age 36 months. They age out. And so the average time that the child was on BTF was only 15 months. Perhaps we could have seen a difference in our variables of interest had we been able to go on a little longer. So to summarize, the majority of published work corroborates anecdotal reports from patients and caregivers. BTF confers unique advantages. Concerns that we've had about bacterial overload, tube clogging, metabolic issues, perhaps they are all overstated. Insistence on the use of a sterile commercial formula may come at the expense of depriving a patient population who might benefit from a diverse plant-based diet. And this group, if any, would be more deserving of it than perhaps the non-ill patient population. We, of course, need larger studies with longer-term follow-up and comparison groups to further strengthen our body of evidence. And now I will turn this over to Shawna.
Great, thank you, Dr. Johnson. Shawna, I'm making you the presenter so you can share your screen.
Okay. There we
Great.
go.
Looks perfect, Shawna.
Yay, thank you. All right, thank you, Laura and Functional Formularies, for this opportunity. I'm honored to be presenting with Dr. Johnson. Her contributions to dietetics and especially BTF are quite extensive. She's not only my esteemed colleague, but also my friend, and I'm blessed by the faith and encouragement she showered on me the last several years. I started my BTF journey about 10 years ago when there was very little guidance and support available. My first baby, the mother and I actually just blazed our own path with recipes, viscosity, and blending, and learning by trial and error because this was before commercial product was even available. I'm no one special. I just happen to have 10 learning years under my belt, specifically with infants and toddlers with special needs. I'm still learning from my families who live BTF every day. And my prayer today is that the tips we share with you will help you in your own practice. There's no one correct way. Each feeding plan is unique because every child is unique and every family is unique. After 10 years, I'm so thankful for more research and then also the new practice recommendations from Aspen. Keep in mind that the tips today pertain primarily to ages 0 to 3. And in this practice, parents lead the decision process, and I just serve as a guide and a coach. When deciding who to offer BTF to, consider, are they clinically stable? Many of these special needs babies are actually critically ill. Is the home environment clean with access to refrigeration? Are caregivers interested and capable? We have some parents with no interest at all. They're perfectly happy with the ease of conventional formula. I have parents with severe anxiety who would struggle. Right now I have a mom with special needs herself, and she just frankly lacks capacity. I also have a parent who was just recently released from jail, and the family is working really hard, but just hanging on by a thread. This baby could definitely benefit from BTF, but the family just isn't quite ready. We also serve homeless families who may not have food availability or insurance support. But truthfully, there's very few that we don't offer blended feeds. Any enterally fed child with no medical contraindications with a capable caregiver is a good candidate. When transitioning from conventional formula to BTF, this is my personal preference for steps. I just start with a broad overview. I present the options, engage the interest of the parent. I send links to the commercial BTF websites and ask the parents to research it. I want them to read the stories and study the ingredient lists, peruse the resources. Then we get back together and talk, and I discover their priorities. What are they looking for? Are they looking for ease, specific ingredients to avoid or to include? Do they want plant-based? Then I send them samples. This just provides a better understanding of what BTF is and what it looks like, because a lot of times all they know is a carton or a can. Then I allow the family to choose home blends versus commercial, and which brand, or even a combination of brands, or a combination of homemade and commercial, or commercial with added ingredients. I have a mom right now wanting to use up her pumped breast milk, so we're giving a combination of breast milk and commercial BTF. And next, we introduce one ingredient at a time using the ingredient list from the BTF product or the recipe chosen by the family, starting as early as 6 months corrected, so that full transition can start about 12 months corrected, or when the baby is showing signs of readiness. Administration can be by pump, bolus by syringe or squeeze pouch, or gravity bag. This is a family-led decision, taking into consideration how the conventional formula was being fed. Bolus or syringe method is preferred, using an O-ring silicone syringe because it has a thinner gasket. It's reusable for months. There's also less resistance with the plunger. Feeds are usually shorter. They can also be combined with oral intake in the high chair, and those higher viscosity blends are easier to administer. It does, however, require more parental involvement. Pump feeds seem to be a more popular choice for my young families just because it's convenient for the parent. Night feeds are easier. However, a thinner viscosity is needed. Feeds tend to be longer and clogs are frequent. It also requires that the child tolerate sitting for extended periods multiple times a day. As most of us know, these pumps aren't made for BTF, so the accuracy and the performance might be impacted due to higher viscosity. So the pumps may under-infuse the volume. So it's important to instruct parents to give the total volume instead of relying on the recorded volume delivered on that pump. So one suggestion I use is to set the pump on infinite, and then when the feed has been delivered, rinse the bag slightly with a little bit of water and prime the pump all the way down to the G tube so that every bit of that formula is delivered. These 0 to 3-year-olds require smaller tubes. 12 French or larger is preferred, but I've also found success with 8 French and even 10 French. The larger bore straight extension set is preferred over the right angle set. Families tend to like the mini backpack for mobility, but performance is impacted because the bag isn't 6 to 12 inches above the pump. So again, make sure that that entire volume is given. We have to watch hang time limits, 2 hours if it's homemade or if food is added to the commercial formula. Commercial blends hang times vary significantly, ranging from about 4 to 12 hours. So if you have a baby who is G-tube or J-tube fed, which requires the continuous feed, the infusion rate is so slow, the safest choice might be to use a commercial blend with a hang time of several hours. For speed, we start the BTF feeds after all the individual ingredients have been tolerated at about 12 months corrected. I love to replace one conventional formula feed at a time. So I match the volume, the calories, and the protein in the water. And then after that first feed is tolerated well, we add a second feed and so on. For the full transition, it usually takes somewhere between 2 weeks to a month, depending on the tolerance and the diagnosis. I encourage parents to follow those body cues: discomfort, bloating, reflux, abdominal distension, or gagging. And then I rely heavily on the parent because they know the child best and they usually actually have excellent intuition. If transitioning from a toddler formula, it could be the first exposure to real food, so you may need to adjust or slow down the transition time due to all that extra fiber and bulk in the gut. I found that we may need to increase calories to keep up with the growth requirements. So for the final goal, I determine the calorie and the fluid needs for the entire 24-hour period, and then I give it one of 2 ways. First, I have the parent mix the entire mixture in a large pitcher with a pump whisk, and then we divide it into the number of feeds for the day, assuring that all of the mixture is given and flushed through the tubes and syringes so that all of those nutrients are received. Or we create a mix for each feed, still ensuring that that total full volume is given for the 24-hour needs. We work towards 4 to 6 daytime feeds, transitioning off all night feeds to a more meal-like breakfast, lunch, dinner, 1 to 2 snack type of schedule. This also facilitates oral eating. For the water flushes, you can add the water directly into the mix, flush before and after feeds, provide boluses between feeds, or give the water by mouth. Just take into consideration the total volume tolerance, your daily feeding schedule, and the desired viscosity when deciding where to administer that water. I found that it's best to add large water boluses either first thing upon waking, and then 30 to 45 minutes prior to a feed, so the water has plenty of time to exit the stomach before those feeds are given. Just keep in mind that no two plans are the same. If allergens are known, make sure that you've trialed every ingredient before giving the combined mixture. In a child with no known allergies or family history of allergies, and the parent chooses, I've also successfully given the blend straight up without trialing the individual ingredients. The majority of my clients are eating orally and working with a feeding therapist, so we make room for oral intake in the feeding plan just to keep that feeding in place, and we don't lose any progress. Oral intake is also a good place to get in additional nutrients that might be missing in the blend. I love to pair oral with tube feeds. We usually start the food about 10 to 15 minutes prior to the tube feed to increase association with satiety. Also consider the family schedule. These kiddos are typically having multiple therapy and doctor appointments each week. And they tend to be a member of a large family with active children in school and extracurricular activities, which creates a need for convenient on-the-go feeds and flexibility with the feeding routine. I would encourage you to keep the big picture in mind when assuring adequate nutrition. Of course, our ultimate goal is a balanced diet. Attempt feeding BTF babies with the same guidance you would provide to an oral eater of the same age, where typically the micronutrients are not micromanaged. I have multiple sets of twins. The tube-fed twin usually eats better than the orally fed twin every time. Last week I was talking with a mom, and the youngest of her 4 is on blended feeds, and she said, "Oh, I wish I could feed all of my kids as good as I feed the baby." Key nutrients to monitor are calcium and vitamin D, so pay special attention, especially if eliminating dairy. Add the vitamin directly or mix in natural food sources. And honestly, if you think about it, very few consumers meet vitamin D requirements, whether they're enterally fed or not. For calcium, the recommended intake for ages 1 to 3 is 700 milligrams. This can be easily added into the mix with dairy products, nut milk, kefir, and soy milk. For vitamin D, it's 400 to 600 international units, which can be met with salmon, tuna, eggs, fortified products, and don't forget the sun. A lot of these babies stay inside most of the time, so I encourage parents to set them in the window and let them get some sunshine or take them out for walks. For sodium, it's easy to achieve with oral intake of snacky foods, but also very easy to add to the homemade blend and the commercial blends that happen to be short of the DRI. This can be achieved by adding like 1/8 to 1/4 of a teaspoon of salt, mixing in broth or vegetable juice. The recommended intake is 800 milligrams, but less than 1,200 milligrams. Protein, just consider the source. The tolerance, absorption, and utilization vary whether it's plant-based or animal-based, and this is parental choice. If eliminating one or more food groups, we must compensate the nutrients from that food group with other sources. For homemade blends, I'm going to discuss the basic recipe in a minute, but just keep in mind allergies to avoid and therefore nutrients to replace, cultural or traditional foods or religious restrictions of the family, diagnosis-related restrictions such as malabsorption or a low calcium diet such as with Williams syndrome. Also take into consideration parental preferences and their nutrition beliefs. I have a parent right now who's very particular about oils. Her son already failed one blend and now he's on a homemade blend for breakfast, plus 2 blends for lunch and dinner from 2 different companies just because mom liked the ingredients from those specific mixes. I have a dad who hunts and he insists on his child having venison, so he blends it right into the plant-based product. I also have a parent who wants more variety of fruits and vegetables, so she blends it straight into a commercial product. For the commercial blends, just review those long nutritionals for each product and then compare it to the daily reference intake for the age of the child. The number of pouches to meet the micronutrients is different for each commercial blend. For every blend I analyzed, 3 or more pouches a day are required to meet the DRI for most nutrients in this young population. So even fortified commercial blends may need additional vitamins. Some of my 12 to 24-month-olds really only need 2 bags a day, and it may take several months to work up to the 3 required bags. So for my population, even those on commercial blends, they get a multivitamin because very few of them are up to the 3 or more bags a day required. If recipe analysis shows shortages, vitamin supplementation is recommended. So look for powdered or liquid because it's super easy to mix in, complete, providing at least half of the DRI or preferably 100%. For the electrolytes, remember oral intake, especially for sodium, and they can be supplemented by an electrolyte solution, powder, or even food itself. So if you're building a recipe, think food groups and variety. You can use MyPlate, the USDA dietary guidelines, or the BTF recipe builder. I looked on the MyPlate plan, which allows you to choose the age and the calorie level. I chose 12 to 23 months at 1,000 calories, and this is the recipe that popped up. 2 cups of dairy or a nutritive dairy alternative, 1 cup of vegetable, but keep in mind you want to do a 2-to-1 ratio starchy to non-starchy vegetables, 2 ounces of protein, 3 ounces of grain, a cup of fruit, and 1 fat. Make sure you include sources of vitamin C, vitamin A, vitamin D, and calcium. For water, just follow the recommendations for age and weight. And aim for your desired balance of protein, carbs, and fat. Add high calorie sources if the volume is limited, from oils, cream, nectar, honey, coconut powder, avocado. We typically aim for at least 1 cal per cc or higher. Analyze your recipes frequently using a quality recipe analysis tool. My favorite happens to be Chronometer because it's an app and my young parents love that. The client can input the recipe and then share it with me or vice versa. And it prints off showing the % of the DRI provided for age. The tools listed here or something similar may be provided by your company or even found free on the web. Monitoring is an option for assuring accuracy. Usually I start with a physical assessment, such as a nutrition-focused physical exam. I do firmly believe in routinely getting your eyes on the child. Measure anthropometrics regularly and plot on growth charts just to assess that growth velocity, taking diagnosis into consideration. I'm personally privileged to visit in the home at least monthly using my own high quality equipment so that my measurements are scale to scale and then on a good stadiometer, which improves monitoring accuracy. With the 0 to 3 population, growth rate is rapid, which requires frequent changes in total calories and volume, so monthly monitoring can improve outcomes. It's not routine for me, but if concerns arise to warrant blood testing, consider a complete blood count or also vitamin and electrolyte levels. So a few years ago, I had a 100% BTF fed child who was admitted to a large children's hospital. The dietitian came in and told the mom, oh, he's certainly going to have deficiencies. So mom called me in a panic and I said, oh, just have them test the CBC plus all those vitamin and electrolyte levels. If checking the levels is indicated, it's typically recommended to monitor calcium, vitamin D, selenium, zinc, iron, B12 if you're following plant-based, sodium, and potassium. But if you're providing the DRI in the feeding plan, there usually should be no cause for alarm or for testing. These are additional resources for recipes, BTF support, and then also assuring accuracy. Let's address some concerns that might arise. When transitioning to BTF, I warn parents to expect an increase in frequency in stools, even up to 5 or 6 a day, especially if there's been no previous food or fiber exposure. Expect a change in the color and smell. That high fiber can cause a lot of gas and bloating short term, but this usually regulates within 3 to 6 weeks. Also assure that the child is receiving adequate free water to prevent constipation. When I mention tolerance, I'm talking about reflux and emesis. Just encourage parents to follow and honor those body cues and go as slow as needed. Consider the stomach size and the previous administration method. If transitioning from pump to bolus, that may take some time to let that tiny stomach stretch. You may need to adjust the mix, the type or viscosity, or decrease the volume by moving the water out or increasing the caloric density, slow down the rate, or even change the delivery method. The higher viscosity of blends has been shown to increase tolerance, so recent attention to viscosity has peaked due to some administration concerns. Pictured here is the IDSI framework with the syringe and the new really cool funnel syringe. This is just a simple process for determining viscosity. I would encourage you to see the IDSI website for videos and instructions, but the main takeaway here is for maximum pump success, aim for the slightly thick 1 to 4 mil IDSI level, which is shown in the gray on the bottom triangle here. The moderate and extremely thick levels, which are shown in the yellow and the green, can be syringed. The benefits of higher viscosity are prolonged gastric emptying, decreased reflux, and decreased aspiration. Viscosity can vary based on brand, the addition of water, the temperature, and the ripeness and season of the fruits and vegetables. As discussed already, the viscosity can affect the accuracy of the pump, so what's delivered may not actually match the setting. The workaround is to administer the entire prescribed volume. This is really important for parents to understand. I had a baby who wasn't gaining weight and it didn't make any sense. And then I was in the home for a feed and realized that the full feed wasn't actually provided as I had instructed. So repeat yourself often and just make sure that caregivers understand the importance. Parents sometimes complain that the thinner liquids clog more due to the little tiny particles. So a trick I learned from a parent is to combine the thin and thick mixes to improve pump performance. The large bore tube size minimizes delivery issues. Try the O-ring silicone syringe or a squeeze pouch feeding method for those thicker feeds. There is a new pump for thick formula that was just recently released. Availability is limited right now, but when you have access, make sure you order the thick formula pump set with the larger bore tubing. If you order the standard set, you'll have the same problems with inaccuracy and clogs that you're having now. For insurance coverage, I've had very few issues. I haven't had to fail a standard polymeric formula first. For the homemade blends, The ingredients are not covered. This actually may be changing in the near future, but the tube feeding supplies are covered. But the high out-of-pocket expense can impact parental decision to use those homemade blends. For commercial blends, all of them are covered in my state and provided by most of the local DMEs. I'm most familiar with Medicaid. It does vary state to state. It happens to be fabulous in my state, and I've had no issues. And in fact, families with babies with developmental disabilities move here just because the nutrition coverage is excellent. The commercial BTF manufacturers can provide letters of medical necessity, order forms for physicians, and then also names of DME companies that carry their products. So now we're going to jump into our case studies. My first one I chose to demonstrate a smooth transition and just a change in administration method. This is a premature female whose mother is a nurse, which was very helpful. For the first year, she was fed fortified express breast milk. Even on an elimination diet, her emesis and reflux was pretty significant. We finally landed on 50-50 express breast milk and goat milk formula by pump. At this time, she was getting about 88 cows per kilo. She also had one feed during nap and one at bedtime. She was on 3 mils of omeprazole a day. At 11 months, we trialed a toddler formula, but she had so much emesis, we had to go back to the goat milk formula. And then we transitioned immediately to a commercial BTF. It took us about a month. We did 1 feed at a time, calorie for calorie. I matched the water. And we were actually able to do it in a lower volume of 155 cc's versus the 175. And we just added 1 feed every 5 days. After the first visit, I did have to increase the calories by just a little bit. So we increased 10 cc's every week for 3 weeks. We could have completed the transition a little bit sooner, but we kept 1 feed of express breast milk and goat's milk until that supply was gone. After 2 months, the omeprazole was down to 1 mil. We switched from hour-long pump feeds to 20 to 30-minute syringe feeds. She didn't have any more feeds during nap or at night. We paired 3 of the feeds with oral feeds in the high chair. Her emesis was resolved. She started talking and walking. Her stools increased to twice a day. I just saw her recently and she had a stomach bug. So for tolerance, we took some of the water out of the blend and added 3 50 cc water boluses, 1 first thing in the morning, 1 30 minutes before her midday feed, and the last one about 30 minutes before bedtime. Now she's up to 118 cows per kilo. After 5 months on the blends, her oral intake is improving. She's up to 1/4 of a cup a day, plus 4 ounces of water from a straw cup. She's a champ and she is thriving. My second case study, I just wanted to demonstrate a challenging home blend. This is a twin male, also premature. The diagnosis I want you to notice is his multiple severe anaphylactic food allergies, which ultimately required home blends. This was an amazing mom. I went to her house like on 2 Saturdays. We played with the blends and the blenders and created and analyzed several recipes. His medications were Miralax and famotidine. We started baby food at about 8 months. Between 13 and 20 months, he had anaphylactic reactions to 3 commercial blends, 2 partially hydrolyzed polymeric formulas, 2 amino acid formulas, and then also multiple vitamin options. So it was considerable work with the allergist and the mom introducing 1 food at a time. Once we had a long list of safe foods, we just started meals using those safe foods at about 21 months. He was also getting a conventional formula at night. By 33 months, we made a full transition to homemade blends using 4 recipes, which I'll share with you in just a minute. We did go through several multivitamins without success and had to regularly monitor those serum vitamin levels. Thank goodness we had a supportive pediatrician who ordered those labs for us. The results were he had an increased oral intake of food and fluids, up to 1 meal a day plus snacks. He was able to wean from his vent for extended periods. He had higher energy levels and improved demeanor. He weaned off of his famotidine, decreased his Miralax, and mom stated his diet was exponentially more nutritious than his orally fed twin brother. He truly had the most balanced diet in the household. These are the blends. We created each recipe in the BTF recipe builder, and then we analyzed it in Chronometer and just adjusted the ingredients and the vitamins until we were meeting the DRI for all of the nutrients. Mom frequently made changes based on seasonal foods or what she found on sale. She would update the recipes in Chronometer and then share them with me through that app, and then I was able to analyze it. The third case study is just to demonstrate the use of commercial blends with added ingredients, and then also using both BTF and conventional formula. This baby also had several food allergies. She started out on an amino acid based formula, and we just added 1 jar of baby food a day and then added more food each week. At 12 months, we transitioned to a plant-based commercial BTF, but mom wanted to add meat and fruit. After starting the BTF, her stools increased to 4 to 5 a day within about 2 weeks, and her GI meds were cut in half. After 2 years and a new diagnosis, we really struggled to meet calorie needs with the BTF alone. So at mom's request, we added a high-calorie hydrolyzed commercial polymeric toddler formula in collaboration with the pediatrician. At 147 calories per kilo, we were just barely maintaining her growth curves. And for my last case study, I just wanted to show is a great success story where BTF was also consumed orally. This is a term male with Prader-Willi. He was on Miralax for constipation. At 9 months, we added purees by tube and then transitioned to a commercial plant-based formula at 12.5 months. We were giving some by mouth and then the rest by G-tube. His grandmother was his daytime caregiver, and she was also an excellent cook. And she loved making special cultural foods for him and then just adding them to the blend. By 22.5 months, he was taking 100% BTF by mouth with those additional foods mixed in. He was on a very regimented schedule and calorie level. But by 30 months, he was 100% table food by mouth. Miralax was weaned, his language skyrocketed, he started walking, and mom and I stay in touch, and he's a thriving elementary student. Thank you again for allowing me to share my experience, and we'll transition to questions now.
Great. Thank you so much, Shawna and Dr. Johnson. That was absolutely amazing with so many practical tips, and hopefully everybody took home so much from that to use in their clinical practices. So if you have a question for either presenter today, please type it into the chat or the question box, and we'll get to as many as we can. While we're kind of waiting for the questions to come in, Shawna, if you want to advance 2 slides for me, please.
I'm trying.
Is it not working? That's okay.
I
was just going to talk about our upcoming webinars that we have, but if everybody goes on our website, we have 3 upcoming webinars over the next 3 months, and one is about administration of Blenderized tube feedings in really, really heavy detail. Oh, here they are. And then one is going to cut into all the research of Blenderized tube feedings, but if you scan this QR code, you can register for any of these. So, okay, for our first question, and this is to Shawna. When you mentioned a few times that you introduce 1 food at a time to assess allergen risk or whatnot. Do you blend that 1 food with the formula they're currently on, or can you talk more about that process and how long in between introductions of different foods and so forth?
Okay. Yes, I usually, well, no, I take it back. It depends on parental preference. So the the third case study that I showed you, the mom actually wanted to blend it into the commercial formula. And so we did, we just blended it straight in. I also have moms who are pump feeding a infant formula, and then we syringe in the baby food right straight into the tube just to get them exposed. So I've done a combination of both. And then, so as far as how rapidly to introduce it, I definitely base that on parental preference and if there's a history of food allergy. If there are food allergies, then we definitely go a little bit slower and maybe give them 2 or 3 feeds first before we add the second feed. But if they don't have any kind of reaction within the first 2 or 3 feeds, we move on to the next food.
Okay, great, thank you. Dr. Johnson, this next one is for you. What is the exact incidence of foodborne illness infections from blenderized tube feeding? Is there at all any increased risk compared to standard formulas? And this is being asked by somebody who works in like stem cell transplant, and so that risk of infection is super important.
Sure. If you look at the whole body of published work on contamination of blenderized tube feeding, most of it's going to report very high levels. But if you look at where those studies were done, they were conducted in countries where safe food handling techniques are quite different than what you would expect in a developed country. So when we looked at that and we saw they were Brazil and the Philippines and Saudi Arabia, and sometimes they didn't even report how they handled it. They just reported the end result. Also, those papers that included commercial formula, there was contamination in them too. So we decided to do some in the US. We did a hospital-based and we did a home-based, and then we compared feeding bag to syringe. And what we found is that in the hospital-based, they were all equally safe. When they all met the FDA guidelines for safe tube feeding. In the home one, we had 50 that we looked at, and 2 were above 10 to the 3 colony forming units, but none were above 10 to the 5. Can I absolutely promise you 100% that blenderized tube feeding is sterile? No. That would, I mean, you get bacteria from the air. So if you want something that's 100% sterile, I probably would not mix up something, from the kitchen. I would probably go with a commercial product, because I believe that you could be, a commercial food-based product, because I believe you could be confident that nothing would grow from there. There's never been any published papers that blenderized tube feeding caused foodborne illness, but I wouldn't say it's out of the realm of possibility. I hope that answers the question.
I think that was a great answer. It's unfortunate we can't ever be 100% confident, but in absolutely no bacterial contamination. But yeah, great answer. To really both of you, do either of you know of any published studies on blenderized tube feedings or purees by G-tube in infants? This person works in the NICU and is thinking about introducing it to in the NICU setting for babies over 6 months, so food appropriate with reflux. But do you know of any actual published studies? I do not.
But Shawna, didn't you transition some of your kiddos very, what would be age appropriate, right? So
I usually go by corrected age, so I wouldn't
right.
probably introduce until 6 months corrected, but it would be just like if you were feeding the baby by mouth. It's definitely within recommendations, especially from the Academy of Pediatrics, to introduce starting at 6 months corrected. So it seems to be, it would be appropriate in the NICU if the child had the oral motor skill to eat food, or well, I guess even through the G-tube, if they were ready, didn't have a lot of GI issues, there weren't any absorption issues. But I don't know of any studies.
Yeah, do you recall in the study that y'all did together, what was the youngest patient?
I
that
think it was 6 months, wasn't it? Didn't you have a 6-month-old? I know we had a couple, didn't we?
yes,
Okay.
yeah.
Okay, and so to the individual who asked that question, their paper will be on the references that gets sent out with the CPE certificate. You'll get a list of all the references and also a list of all the resources that Shawna also talked about. I know we're at
And
2
our
o'clock.
I'm sorry, our paper just got published in print in NCP, but it's been online for about a year at NCP website. Okay,
Do you ladies have time for 1 or 2 more questions?
I do.
Okay. So Shawna, you live in Colorado. So the question was, what state do you live in? So Shawna lives in Colorado, so has great insurance coverage. For a lot of dietitians who live in states that don't have great insurance coverage, do you have any tips or tricks that you can provide to those individuals on how to document maybe to get better insurance coverage and that sort of thing?
So I don't have access to a physician in my organization, but I have asked physicians to write letters. Also, the DME companies are very skilled at managing all those insurance issues. And so if I have trouble, I contact my rep at the DME and they guide me through that. If there's an insurance company that's giving a little bit of pushback, I've also had physician to physician, I don't remember what they call it, but it's like a meeting where the physician that the child sees is meeting with the physician from the insurance company, and they actually talk through the issues and talk about why the child really needs the blend. And every time that's happened, it's been successful.
Yeah, I think they're called, or at least in South Carolina where I'm based out of, I think they're called peer-to-peer.
That might be.
Or something along those lines. So yeah, thank you for those. Teresa, so can you speak specifically to the research that's available to help that Blenderized tube feeding can or doesn't help with thickening stools? So, you know, maybe kids who have diarrhea, like what is the evidence saying specifically about diarrhea and Blenderized compared to conventional standard formulas?
I don't know that we look specifically at diarrhea so much as we just did GI issues, and that may be something Shawna can talk about from her perspective. But what we see is, I think sometimes in some children, we've had reports of, oh, well, you know, a little bit more constipation, so we added water because they weren't used to the fiber. Or we've had issues. I don't remember having diarrhea as a problem. Do you, Shawna, with switching over to real food? It's usually the other way around. Usually switching to the blend helps with the diarrhea. Am I answering the question?
Yeah, I think that's the answer, is that they're asking, will the Blenderized tube feedings help with the diarrhea that sometimes you see on a standardized? Did you guys experience that?
Yes, yes, definitely.
And I think from all the studies that have come out, there was a review paper that just recently came out that really did a nice overview of all the studies. That was one of the biggest GI impacts from Blenderized, was the diarrhea benefit. Not as much with maybe the constipation, but the diarrhea really making a huge impact on the Blenderized tube feeding. So,
well, and I think Shawna made a point when we were talking about it one day, because she's really the pro here, but you need to look at what they were getting and now what they are getting. And maybe with this increase in fiber and types of fiber, perhaps they've never been exposed to before, especially the littles, thinking about that fluid volume and any mobility they may have or other medications, all of that will enter into it. But I'm thinking of a study where they looked at gastric emptying rates on a blend, and there was slower GI emptying rates on blended food. And I think that's probably what, in my mind, is a contributing factor to reducing the diarrhea.
yeah, absolutely. That study is came out of Boston Children's recently. So that author is Dr. Haran and I believe Dr. Rosen out of Boston Children's. That study just came out. So yeah, good point. 2 more questions. When administering pureed baby foods through the G-tube, what really is the viscosity level that you aim for, and how does one achieve that to ensure the tube does not become clogged? Shawna, do you want to talk to that a bit about how do you balance getting that thicker viscosity without clogging? Like, where is this happy medium per se?
Okay. I would say IDSI level 2 would be 2, maybe even 3 would be what we would aim for. And usually my families just, you know, pull the plunger right straight out of the container of baby food and then connect it straight to the extension and then just push it right in, you know, because we're only giving, you know, 2 to 3 ounces, maybe 4 at the most. And so plunging it is definitely easier. I mean, if they did it through the bag, I would say ITSE level 1. So you may have to add a little bit of water and dilute it just ever so slightly, just so it won't clog the pump.
Great, thank you for that answer. And the last question here that we have time for, and Shawna or Teresa, either one of you, Dr. Johnson, so what modifications do you make in the blend for patients who are on a J tube?
I mean, I'll answer, or Shawna, you go for it. Because we had a couple in our paper who were J-fed.
Yes. Well, one, I definitely choose a thinner mix. I do add a little bit of water. Sometimes I make it even a little thinner than ITSE 1. I mean, I make sure that it's a thin liquid, but then to be able to administer it within at least 22-hour period. Sometimes we give our kiddos, you know, a couple of hours off during the day, but I always look for a mix that has a long hang time. So anything else you want to add to that, Teresa?
Well, I might be giving it away, but we recently collected some data from dietitians about J-tube feeding experiences in their patients. And, you know, it's possible that our conventional wisdom about J-tube feeding also needs to be challenged. I'll say that, you know, maybe we don't have to have them hooked up to a pump all the time. So I will just say more to come on that one, but definitely I can say this, there have been children and adults who have successfully bolused food into their J-tubes. I don't recommend that. I mean, this is, you know, everybody's an N of 1, but I just feel like that maybe some of our practices will be changing or at least challenged as we move forward on this. But yeah, for right now, for walking in the light of what we have, I would definitely pick a product that could hang for a long time and make sure it's thin, you know, all the things that Shawna mentioned.
Great, great, thank you. And on that future excitement note that Dr. Johnson just provided us with, we will close out today's webinar. I know there were a few questions we didn't get to, and I apologize for that. I will try and get to those questions individually if your question was not answered. But thank you everybody for spending your time with us this past hour, especially thank you to Dr. Johnson and Shawna for sharing all of your amazing knowledge and company. So I appreciate it. If anybody needs anything from me, just holler. Like I said, your certificates and the full references to what these ladies talked about today will be sent out by the end of the day today in a separate email. Right? Thanks everybody. Have a good one.
It's a privilege. Thanks, Shawna.
Thank you.
Bye ladies. Thank you.